Hello, my name is N.Contreras and today I will be doing a presentation on reinforcing oral health education and positive habits in the elderly communities. Aging populations and dental health. The demographic of older adults 65 years of age and older is growing across the globe due to advances in technology. According to the World Health Organization, or WHO, by 2030, the world's population of people aged 60 years and older will increase from 1 billion in 2020 to 1.4 billion. By 2050, the number will double to about 2.1 billion. Consequently, there will likely be an increase of elderly patients in the dental practice in the coming years. This poses a challenge for dental hygienists who are not very familiar or experienced with treating geriatric patients and taking into account the unique challenges they face. This presentation will explore the factors that put elderly persons at risk for poor oral health, how poor oral health can negatively affect their lives, and how dental hygienists can prevent these conditions by providing this growing population with oral health education and promoting healthy habits. Challenges. The elderly population face a variety of different challenges when it comes to having optimal health. Some of those challenges include lack of finances, health insurance, and familial support. One major barrier is the lack of insurance. Medicare only covers narrowly defined medically necessary procedures. In many states, Medicaid programs do not cover dental services for adults. This results in adults paying an increasingly portion for their dental procedures out of pocket as they age. Those who are financially unstable may have to neglect their oral health due to lack of finances. Poor habits can also affect the elderly person's oral health. This can include the use of tobacco products and inadequate oral hygiene routine at home, such as lack of flossing or brushing. Declining overall health can also contribute to poor oral health. Some conditions include cognitive decline and physical disabilities. Many older adults who develop cognitive and physical disabilities eventually move into long-term care facilities. Most elderly people who reside in long-term care facilities have untreated cavities. Among these persons, most also have major or urgent treatment needs. Many long-term care residents have gingivitis, an important marker of poor oral health among elders that may indicate a need for assistance with oral hygiene. It is estimated that only 48% of long-term care residents have good or better oral health, a value which decreases to 40% for homebound elderly. It is also estimated that among edentulous persons, 81% of residents in long-term care facilities have no dentures or have inadequate dentures. Overall, the oral health of long-term care residents and homebound residents is a lot worse than that of younger elderly living independently. Oral diseases that affect the elderly. Some oral diseases that affect the elderly include dental caries, periodontitis, gingivitis, and oral cancer. Receding gums associated with periodontal disease expose root surfaces to caries causing bacteria. This is more common in older adults. Vulnerable elderly persons, like those living in long-term care facilities and those who are homebound, have higher levels of untreated dental disease. Xerostomia. A condition that can cause oral diseases in the elderly includes xerostomia, also known as dry mouth. Xerostomia can be caused by chronic conditions and medications taken to treat these conditions. Commonly used drugs that can induce dry mouth include antidepressants, antipsychotics, beta blockers, and antihistamines. Saliva protects teeth against dental caries by lubricating the mouth and gingiva, which in turn reduces bacterial growth and provides minerals such as calcium, phosphate, and fluoride needed to remineralize tooth surfaces where tooth decay is just beginning. Xerostomia can lead to an increased risk of dental caries, sores, yeast infections, angular colitis, and increased plaque and tartar. Edentulism. Edentulism or tooth loss may cause eating, digestion, and nutrition problems as well as a decrease in self-esteem. Poor oral health can limit food choices and diminish the pleasures of eating. Extensive tooth loss may impair chewing efficiency. Because having 20 teeth is considered necessary for functional dentition and chewing with removable dentures is at least 30 to 40% less efficient than chewing with natural teeth, persons with extensive or complete tooth loss are more likely to substitute easier to chew foods such as those rich in saturated fats and cholesterol for foods high in carotenes, vitamin C, and fiber. Among older persons, tooth loss has been shown to be associated with both weight loss and obesity. Extensive and complete tooth loss may also restrict social contact and inhibit intimacy. Tooth loss can affect speech, which in turn limits social interactions. It can also change the shape of a person's face and so affect physical appearance, which can lead to lower self-esteem. Pneumonia. Poor oral health can also lead to pulmonary complications. Geriatric populations are more likely to acquire and die from pneumonia, especially aspiration pneumonia, than any other age group. This is because some elderly individuals, especially those living in long-term care facilities, frequently suffer from conditions such as dysphagia, xerostomia, lack of physical or cognitive functions, which restrict them from being able to properly take care of their own oral hygiene at home. When an individual presents with poor oral hygiene, pathogenic organisms may colonize the oral cavity. These pathogenic organisms may be aspirated by the individual and therefore causing pneumonia. Individuals in this particular age group who have compromised immune systems are especially susceptible to aspiration pneumonia. How to help. The role of the dental hygienist. Hygienists can help through recommending the right procedures for each individual and through patient education. Poor oral health is largely preventable. There are a few ways for a hygienist to interfere. For example, the use of fluorides, whether self-applied, such as using fluoridated toothpaste, professionally applied fluoride, or fluoride delivered through community water systems, help to reduce dental caries incidence in adults. Increased exposure to fluorides has been a major factor contributing to the decline in dentulism over the past 50 years. Fluorides in antimicrobial rinses, such as chlorhexidine mouth rinse, are also effective in reducing root caries incidence. Effective interventions to prevent and control periodontal disease include scaling and root planing and at-home oral hygiene education. Oral hygiene education is very important because many elderly may be facing difficulty with oral hygiene routines due to conditions such as arthritis. This is an area where we can be of help in gaining more knowledge on oral hygiene instruction, and the elderly's particular challenges can be very beneficial to our patients. The role of the dental hygienist, Part 2. Hygienists can also help the growing elderly population by educating caregivers. Depending on the illness or condition the older adult patient is suffering from, they may be incapable of performing their own daily oral hygiene care routine. These frail older adults who rely on caregivers may not always receive the oral health care that they need, putting these patients, especially those who reside in hospitals or nursing homes, at higher risk for infection. Geriatric patients are being exposed to potentially fatal infections in facilities where they are supposed to be safe and well taken care of. Not only does poor oral health have the potential to cause dangerous conditions such as pneumonia, but it also results in a significant decline in an individual's quality of life. For this reason, it is of utmost importance that caregivers learn to provide and maintain good daily oral hygiene care for elderly individuals who struggle to take care of themselves. Thank you for listening to this presentation, and I hope you can apply this new knowledge in a clinical setting.